Good afternoon. I am Ashley Anderson. On behalf of the Atlanta Suburban Chapter of Delta Sigma Theta Sorority Incorporated and the Empowerment Resource Center, I would like to welcome you to our second session of the Ending the HIV Epidemic Equal Access Everyone's Voice virtual conference. This session is titled Hearing Every Voice, Prevention, Protection, and Possibilities. Before we hear from our partner, ERC, I would like to introduce our moderator, Ms. Madison Carter. Madison Carter is a reporter for the Atticus team with 11 Alive News in Atlanta, Georgia. She grew up in Northern Virginia and joined the 11 Alive team in April 2021. Madison attended Syracuse University, where she earned a degree in broadcast journalism and policy studies. Madison began her career at WVIR-TV NBC 29 in Charlottesville, Virginia. Madison was honored with 2 Virginia Associated Press Awards for her investigative docuseries into the criminal justice system and parole in the Commonwealth. From Charlottesville, Madison moved to Buffalo, New York, where she was hired as a reporter and was eventually promoted to the I-Team. As an investigative reporter, she focused on uncovering corruption, racism, and political accountability. Madison received international recognition for her exclusive and extensive reporting on protests following the killing of George Floyd and coverage of the 75-year-old protester who was shoved by police. She was named News Personality of the Year by the Buffalo News and recognized by the NAACP for being a critical voice for people of color and using her platform to push the envelope in the criminal justice system. She is a member of the National Association of Black Journalists and served as president of the Buffalo Association for Black Journalists. Her favorite activities include finding complicated recipes to try, looking for unique shops and restaurants in the neighborhood with her mean and very cute dog, Jax, napping, and bringing the DC brunch experience to wherever she lives. I will now turn it over to Ms. Madison Carter.
Oh, I forgot I put that in my bio. I do love brunch. Thank you so much for having me. Again, I work at 11 Alive. Our Atticus team, I lead our national investigative team for my company, as well as anchor the morning news there. But I'm really excited to be here to talk about this really important panel as we talk about ending the HIV pandemic today on World AIDS Day. I'm not going to do a lot of the talking, but I'm going to introduce the people who will. We have a number of panelists here who are going to be talking to you about PrEP and prevention and how this will go in aiding the end of the AIDS pandemic here in the United States and across the world. So we're going to begin with Lauren Elaine, and I'm going to give you a brief version of their bios. They are much, much more accomplished than this, but just to give you a taste of who they all are. Miss Elaine, Lauren Elaine, graduated from James Madison University, also a Virginia girl, attended the University of Texas at Austin as well. But this is interesting. She decided to focus on healthcare after she transitioned from a career originally intended for music, but she keeps music as a very cherished hobby, she says. She served 3 years in the Air Force as a family nurse. And then in 2020, she joined the clinical staff at the Empowerment Resource Center, our partners for today, where she's helping patients who are living with HIV and other STDs, also working with the LGBTQIA population, and of course, fighting the HIV pandemic through prescribing PrEP and education. Our next panelist is Ms. Brittany Smith. Brittany is a family nurse practitioner here in Atlanta. She has worked in healthcare since 2007 and is a graduate of Georgia Southwestern State University. She came to ERC recently after she completed a postgraduate fellowship in LGBTQ plus health in Brooklyn. Ooh, New York. I'm also a New York girl. The fellowship offered a strong focus on primary care, HIV and STI prevention and treatment, went across a number of things there. So now she's with the ERC helping, of course, to aid in education of PrEP and HIV as well. And finally, we have Ms. Janae Rollins. She is an outreach team lead and has served with ERC for the last 2 years, over 2 years at least. She assists with coordination of testing strategies for both Fulton and Gwinnett counties and attended Georgia Southern University. She also says she's dedicated to ensuring our most vulnerable population receive access to healthcare. So those are our panelists for today. With that, I'm going to send things over to Ms. Tanisha Taylor because we're going to begin with the presentation. And as we do the presentation, I want to encourage people to be asking questions. I will pop in and ask them as we go through to each of our panelists. If you have them, you can put them in the chat, or if you're with us on Facebook, right on the Facebook pages there for both the alumni chapter and also the ERC, they'll be feeding me the questions and we'll pop those in throughout. All right, Ms. Tanisha, we'll let you take it from here.
Thank you so very much, Madison, for that introduction. My name again is Tanisha Taylor, and I proudly serve as the Director of Clinical and Programmatic Operations for Empowerment Resource Center. I've been a member of this team for the past 5.5 years, and we are so excited to be partnering once again with our partners at the Alumni Suburban Chapter of Delta Sigma Theta. A little bit about me. I have over 17 years of leadership experience, of which the last 6 years have been dedicated to nonprofit organizations. And I'm proud to really be here today as we celebrate World AIDS Day. I'm going to attempt to share my screen here and get you on with our presentation. Okay. All right, so let's get started first with the mission of Empowerment Resource Center. Our mission is to provide programs, services, and community-level solutions that improve the quality of life for the communities we are privileged to serve. Our vision is achieving better health outcomes, one client at a time. A little bit more about Empowerment Resource Center. We were a very grassroots organization, starting first and established in 2003, but incorporated in 2006. Our CEO and founder, Ms. Jacqueline Brown, started this organization given her passion and dedication to helping women battle HIV and learn more about HIV and how they can protect themselves. Over the years, we began to grow and expand our programs, and now we are serving a vast array of populations up to and including the LGBTQIA community, as well as all men and women of all genders and races. We are a nonprofit 501c3 and very much a community-based organization. As Director of Clinical and Programmatic Operations, I oversee our mobile outreach program, and currently, while our clinic is located in Fulton County, we provide services in DeKalb County, as well as Clayton County, Cobb County, Douglas County, as well as Gwinnett County through our mobile outreach program. Across the state of Georgia, clients are able to access our services through our telehealth program. We also provide a comprehensive continuum of care. We are certified through the Georgia Medical Composite Board Clinic. We have a wonderful clinical staff, of which you'll hear from some of those today, led by our medical director. We have 3 APRNs, 2 certified medical assistants, and a host of supportive staff that really help ensure our clients are scheduled and taken care of accordingly as they come to our clinic for services. We are nationally recognized as an STI and family planning clinic by the U.S. Health and Human Services Department. What that basically means is that family planning is all about the prevention and the conception of a child. So if anyone is interested in any of those services, you can certainly reach out to us. And lastly, we have a behavioral health program of which we actually deliver substance abuse and mental health therapy, and we have a 3-year accreditation with CARF. So without further ado, I would like to pass the mic over to Lauren Elaine, who will take you through the rest of this presentation.
Thank you, Tanisha. I appreciate the introduction. So the first slide here is a picture of our clinic. This is where me, the APRN, as well as Brittany, our other APRN, and we have one other that comes in 1 day a week, and this is where we work. So just to give you a visual, if we go to the next slide. Thank you. So what do we do here at ERC? We provide free and low-cost healthcare programs and services in our comprehensive intervention clinic, and that includes management of STDs and treatment of STDs, HIV diagnosis and stabilization, prep and PEP prescribing, as well as education. And then we also have programs for outreach, specifically our mobile outreach vehicle experience, where our team of outreach coordinators goes out and does HIV testing in the community. And Janae will talk more about that when she gets to her presentation. So one of the other programs we offer are our behavioral health services. ERC provides a fully integrated multiple disciplinary and behavioral health services in an outpatient setting, which targets individuals struggling with mental health and or substance use disorders. We are able to offer substance abuse treatment and recovery services, mental health therapy, case management services, and drug screening and DUI services. Thank you. So what is HIV? So HIV is defined as human immunodeficiency virus. HIV is a virus that causes harm to the immune system, specifically the white blood cells, or called the specific cells that are affected by HIV, or the CD4 cells. These are the cells that fight infection in your body. So when the HIV virus infiltrates the body, it causes damage to these cells, thereby making your body susceptible to opportunistic infections. If HIV continues to go unchecked, it can eventually lead to several infections and then unfortunately death. This next slide here is, how does the virus work? And I really like this slide because it shows how a healthy CD4 cell is infiltrated by the virus and replicates inside the cell. So the first stage is that the virus attaches to the cellular membrane. It next fuses to the cell. And by the way, that little dot in the middle of each cell is the nucleus of the cell. The next stage is the virus enters the cell through the cellular membrane. And then we have an enzyme called reverse transcriptase. And what that does is it transcribes the genetic material from the virus into the cell. We next have another protein called integrase, or an enzyme called integrase, which causes the reconstituted or transcribed genetic material to enter into the nucleus of the cell. We move on to the infected cell, which starts to produce new virus from the nucleus. And then again, it needs a special protease or another enzyme to release the new viruses, the newly manufactured viruses, out into the cell so that it can attack other CD4 or white blood cells. And so at each point in this process, we have medications that can stop the process of these, not just one site, but several sites. We have drugs called antiretroviral therapy that can stop several of these processes in their tracks so that HIV does not progress through this particular model, through this process. And Brittany's going to talk more about that in her presentation. So HIV versus AIDS. HIV can progress to AIDS, like I said before, if it's not treated. An AIDS diagnosis occurs when the CD4 or the white blood cell count is below 200. It's also designated AIDS when a person is suffering from one of the many illnesses or opportunistic infections caused by AIDS, such as fungal infections, pneumonia, influenza, and cancer. People living with AIDS have a very high viral load and are considered most infectious. AIDS causes your body to not be able to fight other diseases such as flu and pneumonia, like I said before. And once a person receives an AIDS diagnosis, they will always carry that diagnosis, even if they revert back to a viral load that is undetectable. Women in HIV is very interesting because it's not a virus we think of that is really attached to women. We think of this more as a man's virus or men's virus, specifically a gay men's virus. But we do see a very significant portion of women infected with HIV. In the United States, nearly 1 out of 3 new HIV infections occurs in a woman or girl. However, in some areas of the country, the rate is much higher than that. Women are still primarily diagnosed in conjunction with pregnancy. For example, they're going in for their prenatal appointments. They are not randomly, but they are tested for HIV due to pregnancy, and they're found to be positive. Or a woman's not feeling well, she goes to her family doctor, she's tested and she's HIV positive. So we still have a large group of women that are not going out and being tested specifically with the idea that I want an HIV test. So that's something that we have to change. 1 out of every 9 women in this country are living with HIV after the age of 50. So in Atlanta specifically, and this is a statistic from 2017, there are approximately 37,000 people living with HIV in Atlanta. 70% of those are Black, while only 6.8% are Latin or Latinx and 18% white. And of those people living with HIV in Atlanta, almost 20% are female. So I'm going to go ahead and turn over the presentation to Brittany Smith, my colleague and nurse practitioner.
Would I be able to ask a few questions here?
Oh yeah, absolutely.
Okay.
Absolutely.
Just because I know your expertise here, and you passed the slides, and I want to talk a little bit about women and HIV. Tell me a little bit about what symptoms might look like as they appear. Do they look different in women versus men? You said people may not be feeling well. What might that look like?
So that's a great question. Women and men generally show the same symptoms. However, women can suffer more vaginal infections because of decreased immunity or a immune system that is not in top shape. So for example, they can acquire infections like bacterial vaginosis, yeast infections. They can also acquire, or are more likely to acquire, pelvic inflammatory disease, which is a very serious infection of the uterus and is typically caused by chlamydia or gonorrhea. And as well, they can be diagnosed with cervical cancer while living with HIV, and that is not seen in men, however, because men lack a cervix. So women with HPV are more likely to have cervical cancer if they are HIV positive.
And then one other question, you mentioned here at the end that women aren't typically going to get tested for HIV. That happens if you're pregnant and they just end up running a test, and there's this stigma. So how do we bring more awareness to testing in women? Should there be a regular schedule? Should we get testing every year like you do with your annual gyno appointment? What should that look like?
I think you mentioned a couple of really good points. I think that a lot of primary care providers are just not talking about testing for STIs, specifically HIV. So I think it really behooves us as providers out there, not just here in an STD clinic, but in the general population of primary care, to say to our patients, you know what, we're going to test you for HIV just like we test you for everything else. Just like we're looking at your blood counts or your cholesterol, this should be part of routine testing. Because like I said, you saw the statistics, and women are at very significant risk for HIV infection. So I want to see that at the primary care level.
Okay, great. And of course, if you all have any questions, please throw them in the chats. They'll get them to me. I'll be able to ask our panelists as we go. But now I'll send things over to Ms. Brittany Smith for your part of the presentation.
Thank you. And thanks, Lauren. So I'm actually going to pivot a little bit and talk about HIV prevention. But I feel like in order to understand HIV prevention, we have to really understand how it's transmitted. And I know firsthand from having conversations with patients that there are a lot of misconceptions out there regarding how HIV is transmitted. So there are 5 different modes of transmission. That's vaginal secretions and anal secretions. And this is through homosexual contact and heterosexual contact. Like Lauren mentioned before, a lot of people honestly think that HIV is a white gay man's disease, and that is not the case at all. HIV does not discriminate. HIV can be transmitted through ejaculate, and that's also pre-ejaculate too. That's another misconception, that you can't get HIV through pre-cum, and that's not the case, because you can. And then there's also blood and breast milk. And then just FYI, HIV does not survive long outside of the human body, and it can't reproduce outside of a human host. So with that being said, HIV is not transmitted by hugging, mosquitoes, ticks, kissing, sharing toilet seats, saliva, tears, or sweat. And then just to kind of mention a few more statistics to paint a clearer picture of who is affected by HIV and how. There are 1.2 million people in the United States living with HIV, and there's about 13% of them that are unaware. So if you do the math, that's a little bit over 120,000 people walking around with HIV and they don't know it. Blacks and African Americans make up about 13% of the US population, but we also make up 41% of all new HIV diagnoses. And then just to kind of compare to our Hispanic and Latino population, that's about 18% of the US population, and they make up 29% of all new HIV diagnoses, Caucasians make up 60% of the population and 25% of all new HIV diagnoses. So when you hear these numbers and you see the difference, it's kind of disheartening when you think about it. And then also just a little bit more specific, the rate of new infections is 13 times higher in Black women than white women and 4 times higher than Latino women. And then, like I said before, HIV affects everyone, regardless of your sexual orientation, your race, gender identity or expression, ethnicity, it does not matter. So before we talk about PrEP, which is a method of prevention, I want to go over a few more. So there are different methods to prevent HIV. One, reducing sexual risk, like with condom use or abstinence. Reducing risk from mother to child. There are medications there, like Lauren mentioned during prenatal visits, that we can take to prevent transmission from mother to baby. Reducing risk from drug use. If you're doing like injection drug use, there are needle exchanges in the community that will actually give you a clean needle if you give them a dirty needle. And it's all about harm reduction. There's also with alcohol use. For some reason, we don't make the best decisions when we're intoxicated. So when you mix sex and intoxication together, the outcomes just are not that great. And then also there's HIV treatment. So a couple of years ago, there was a campaign released called U equals U. Undetectable means undetectable equals untransmittable. And what that means is if someone is living with HIV, we monitor their viral load. And if you're taking your medication as prescribed, meaning you're taking it every day, your viral load will be suppressed, meaning that it's undetectable, meaning that the amount of virus that's in your blood is so low that it can't be picked up by a lab. And if that's the case, if your viral load is undetectable, then technically you can't transmit it through sex. So that is definitely a method of prevention, because if you're managing your virus and you're undetectable, then you cannot spread it. And a lot of people want to know why. Like, why are the numbers just so different? Well, like I said before, and like Lauren mentioned, still a lot of people think that HIV is a white gay man's disease. There's a lot of stigma around homosexuality in the African-American community that cause a lot of people to be silenced about their lifestyle for fear of judgment. There's a lingering distrust in the medical community. I'm sure a lot of us have heard about the Tuskegee experiments that were not that long ago, and it spanned over 40 years. So there's still some lingering mistrust in the medical community because of that. And we see it a lot with vaccines and all of that stuff. The increased amount of STDs, which cause a breakdown in the skin barrier that's normally there to protect the body or protect from HIV getting into the bloodstream, but because of their ulcers or inflammation or something like that, it's just a little bit easier for the HIV to get into the bloodstream. Then also there's a lot of poverty, unfortunately, in the African-American community, and this results in access issues, regarding information for treatment, prevention, and all of that. So now we want to talk about PrEP a little bit. PrEP stands for pre-exposure prophylaxis. And for those who don't know, prophylaxis basically means measures that are taken to prevent an infection or disease from occurring. So PrEP is a daily medication that you take every day, and it reduces your chances of getting HIV from sex or injection drug use. If you take it as prescribed, like I said, every day, it reduces your chance of getting HIV from sex about 99%, and from drug use, injection drug use, about 74%. But just keep in mind that PrEP only protects against HIV and no other STI. So we do recommend condom use. We encourage condom use with every encounter, because you're protected against HIV, but you're not protected against other STIs like gonorrhea, chlamydia, syphilis, etc. So there are currently two drugs on the market right now that are approved for PrEP by the FDA, and that is Truvada and Descovy. Descovy right now is only approved for people who are assigned male at birth. So if you are assigned female at birth and you want PrEP, you will likely be prescribed Truvada. And these meds are actually part of multi-drug regimens that are used to treat HIV disease as well. With that being said, before you can start a PrEP regimen, we must test you for HIV to make sure that you do not have it. Because one thing we don't want to do is have you on this drug when you actually have HIV, because this drug is not strong enough to treat HIV by itself. And this is how resistance is made with the HIV virus, and it'll make it a whole lot harder to treat your HIV. So the next question is, who should use PrEP? And that's pretty much anybody who's having sex, honestly. If you do not have HIV and you've had anal or vaginal sex in the past 6 months, and you have a sexual partner who has HIV, especially if they have an unknown viral load or detectable viral load. Remember I said U equals U. Undetectable equals untransmittable. So if you don't know this person's viral load, or if they have a detectable viral load, then PrEP, you would be a great candidate for PrEP to protect yourself. And also, if you have sexual partners with unknown status, if you're having people with sex and you don't know if they have HIV or not, you should get on PrEP to protect yourself. If you're not consistently using condoms, or if you were diagnosed with an STI in the past 6 months, I mentioned before how STIs increase the risk of HIV. Also, individuals who inject drugs and they have an injection partner with HIV, or they're sharing needles, periods, syringes, or other equipment to inject drugs with people they know or don't know, then you are definitely a candidate for PrEP.
Brittany, can I jump in with a couple questions here?
Sure.
First one, can you give me a refresher on the viral load and what that might mean?
Okay, so a viral load is basically the amount of virus that's in your body, that's in your bloodstream, the amount of HIV. So when you have HIV, you come in quarterly for repeat labs. And what we like to do is to check your viral load. When we check your viral load, we're able to see if you're taking your medication or not. Because if you're telling me that you're taking your medication every day and you have this really high viral load, either you're not taking it or we need to investigate a little bit further to see if you have some resistance. But either way, if your medication is working, you're taking it as prescribed, then your viral load should be suppressed. And when I say viral load, again, I'm basically meaning the amount of virus that's in your blood. And if you are suppressed, and your viral load is undetectable, that means that we've sent your blood to the lab and the amount of virus in your blood is so low that it can't be picked up by a lab. And that's what we want to see. And that's honestly a way to prevent HIV transmission, because if you have HIV, but your viral load is undetectable, meaning that it's so low, you cannot transmit it.
So when you say, if you don't know your partner's viral load, you really mean anyone who's having sex could be a candidate for PrEP.
Yeah, so if I know my partner has HIV and I know their viral load is high or they have a viral load, that means that they can transmit it to me. Okay. And because they have this viral load, I need to get on PrEP so I can protect myself. Now, also, I honestly feel like if you have a partner with HIV and their viral load is undetectable, I don't want to put all of that. I don't want to put my health in their hands. So yes, you can tell me that you have HIV. You can tell me that your viral load is undetectable. That's great. But maybe you may run out of medication, or you have this, you're going through something, you're depressed and you just don't want to take your medication. Your viral load is going to go up. And I want to make sure that I'm already on PrEP and I'm protecting myself. That way, whether you decide to take your medication or not, whether your viral load is undetectable or detectable, I am protected.
So a question came in from our audience here. Latonio is asking about what age is it recommended? And I think even part of my question was saying, if you're having sex, you may not know this person if they have a viral load. And should younger girls who are becoming sexually active become candidates for PrEP?
So, I mean, it's definitely a conversation to have if they're seeing a pediatrician. But, if they're having sex, it's all about harm reduction, risk reduction. I definitely think that's a conversation to have with a pediatrician as far as how young. But if they're having sex, we want everyone to be protected, especially our women and girls. So if they're old enough to have sex, and we have to monitor those certain labs, which we do when people are on PrEP. We bring them in frequently to repeat labs, check their kidney function and all that stuff to make sure everything is okay. But that's definitely a conversation that someone can have if they're seeing a pediatrician or their family doctor.
I can jump in as well on this one too. So PrEP is not recommended in adolescents till age 18, but Truvada, the drug that we take for PrEP, is authorized in kids 12 and up, and that's kids who are HIV positive. So conceivably, like Brittany was saying, you could see your pediatrician, have a conversation, and some may be willing to go on or to use that drug for PrEP use almost as an off-label use if they're younger than 18. So again, that's a conversation to have with your doctor.
Okay, perfect. Thank you. And please keep asking questions. I'll continue to jump in where I can, but I'll send it back to you, Brittany.
Okay. Then I also wanted to mention, as far as using PrEP, Truvada, and Descovy, if your risks for HIV is from anal receptive sex, we definitely recommend that you take your PrEP for a minimum of 7 days, because that's how long it takes to reach maximum protection. And if you're at risk from HIV from vaginal receptive sex, we definitely recommend that you take it for 21 days straight prior to not. We encourage condom use with every encounter, but we definitely encourage backup methods for the first 21 days if you're having vaginal receptive sex. but we encourage condom use with all encounters. So the next one we're going to talk about is PEP. And I know the names sound really familiar, but PEP stands for post-exposure prophylaxis. And again, prophylaxis basically measures taken to prevent an infection or disease before it occurs. The difference with PEP, though, is taken after a single high-risk exposure to stop HIV seroconversion, which is basically time from exposure to virus to when the antibodies show up in your blood. Now, PEP is highly effective in preventing HIV when it's taken as prescribed. Now, with PrEP, you take it every day, but as far as post-exposure prophylaxis, you're only taking it for 28 days. But please keep in mind that you have to take it for the entire 28 days. Don't take it for 14. Don't take it after you take a test 1 week later and your test is negative and you're like, oh, I can stop it. No, you have to take it for the entire 28 days. And then you also have to take it within 72 hours of 3 days of exposure. Every hour counts. The sooner the better. But please, you have to take it within 3 days. It's likely ineffective after that. So some examples of situations that would warrant PEP: occupational exposure, like a needle stick, sexual assault. If God forbid you were raped or someone you know is raped and they don't know the status of that person, they don't know if that person has HIV or not, then that definitely warrants a PEP regimen. And then also if you have a sexual encounter with someone and you don't use a condom, or the condom breaks or the condom slips off, that's a great situation that would warrant PrEP. And then also sharing drug equipment like needles, and you don't know this person, or you may know this person and they have HIV, that's also a great opportunity for a PEP regimen. And PEP and PrEP, they both kind of work the same. They both stop the virus from replicating after the exposure. Cells that are originally infected with HIV, they'll die off naturally. But also just keep in mind, if you find yourself using PEP regimens often, then it's probably time to have a conversation with your provider about starting PrEP. So next question, why is PrEP and PEP important? So if you look to the right, I won't go over all of these, but if you look to the right, you'll see, this is from 2019. It was 9,123 Black African-American male-to-male sexual contact that were diagnosed with HIV, 9,123. If you break it down to their white counterparts, it was only 5,805. If you break it down to Black African-American heterosexual women, 3,473. You break it down to the white counterparts, only 954. So you can see the difference in those numbers there. And if the current rates persist, there's a lifetime HIV risk for African Americans. 1 in 48 African American women will be diagnosed in their lifetime with HIV, 1 in 20 heterosexual African American men, and 1 in 2 African American gay and bisexual men will be diagnosed if the current rates persist. There's a lot of confusion I also want to mention between PrEP and PEP. I have friends, I find myself talking about it all the time, but I do have friends who are like, why did they name it the same? Why are the names so similar? Who can remember the difference between PrEP and PEP? So I kind of talk about it, and I think a lot of people do at this point. We kind of talk about it and relate it to birth control. So you take a birth control pill every day to prepare yourself in case you have a situation that can result in pregnancy. So it's the same with PrEP. You're taking PrEP to prepare yourself just in case you have a situation that can result in HIV. You're taking the pill every day, just like you take a birth control pill every day. And then when you have PEP, you can relate that to a Plan B pill. You take a Plan B pill after one situation, one single incident that can result in pregnancy, just like you would take PEP after one single incident that could result in HIV. So PrEP, you're preparing for a possible encounter. PEP, you need to get some PEP in your step and get to the hospital really quick so you can get your PEP regimen because you were exposed by a single encounter and you're not on PrEP every day. So there are some challenges with HIV prevention, especially in this community. And like I said before, a lot of people are unaware of their HIV status. I said there are 1.2 million people in the United States living with HIV, and 13% don't even know that they have it. So if you don't know that you have it, you're unaware that you're transmitting it. So we have to encourage people to get tested. If you're having sex, unprotected sex, whatever kind of sex you're having, we definitely encourage you to get tested, whether it's with your primary care. There are a lot of organizations, including Empowerment Resource Center. You can come and get an HIV test for free. We are more than welcome and more than happy to serve this community. There's also a lot of stigma. A lot of people have negative judgments, attitudes, and behaviors towards people living with HIV. And there's also a lingering fear of discrimination in people who are living with HIV. And because of that, they're not seeking the medical care that they need, which is proven to have negative effects on their health outcomes. Then also homophobia. There, like I mentioned before, there's a lot of homophobia in the African American community. And the homophobia isn't just external. You know, there's homophobia from family members and churches and other organizations, but there's a lot of internal homophobia too, which makes it difficult for some folks to be upfront and open about the risks that they're taking that can result in HIV. If I am a Black male and I'm having sex with males, but I was raised that homophobia is wrong, I'm not going to be open up front with my family members. I'm not going to be open and upfront with my providers and say, hey, I'm having this type of sex. I think I qualify for PrEP. We're not going to do that. So that's also something to consider as well. I talked about the increased STI rates, socioeconomic status, as far as like racism and discrimination, which is alive and well, and the medical mistrust in the Black community. Also, people don't want to see healthcare, and then because of different socioeconomic statuses, people seek healthcare and they're not receiving the quality healthcare that they deserve. And then a lot of times there's just a lack of knowledge by medical providers. But I say that in a sense that a lot of times it's just not mentioned. I mean, if you think about it, how many times have you gone to your provider and they've offered PrEP to you when you told them that you were sexually active? And it's not that people don't know about it. Some people just aren't as familiar because it's not routine. And then I've had some patients say that they brought it up to their primary care and they're like, oh, you don't need that. You know, so it would make, personally, if someone told me that, I would not want to pursue further because I would want to, I don't know, reconsider it. But either way, if you encounter any type of situations with your primary care or any type of clinic, and it just makes you uncomfortable, feel free to come to Empowerment Resource Center. Lauren and I are here and we'll be more than happy to get you on PrEP or PEP. And then also just keep in mind that people are living so much longer with HIV. We got to erase the stigma. We can prevent it, we can treat it, and you can live a long and healthy life. And Janae, I'm going to kick it to you.
All right, thank you. Thank you, Brittany. So I'm going to speak a little bit more about our community outreach services. I work in the outreach department here at Empowerment Resource Center. So basically we go out into the community and provide these same services for people. We provide free HIV testing throughout the Metro Atlanta area and more. We also provide linkage to care, referral programs, as well as PrEP that we offer in the clinic. We provide health literacy programs, which are focused in prevention. We also provide risk reduction counseling, as well as providing resources to our community partners. So when we say outreach, we think of, we go out into communities and we provide free HIV testing. So we're bringing this service anywhere that it's needed. People that may not be able to get down to a place, or somewhere, some people that just may not have the time to go to a place, we want to make sure that we provide this access to these services to everyone. So some examples of places that we go to, we provide our services for transitional housing facilities, rehabilitation and recovery facilities, as well as college campuses, gas stations, bus stops. You may see us anywhere, to just name a few. So if there's any places or anybody that you have in mind that you think could benefit from our service, we're always open to partnering and working with them. Or even if any of you would like to partner with us, our contact information will be at the end if you want to reach out with us, because we always love to come to your communities and make an impact. So these are the testing technologies that we use in the outreach setting. The one that you see here on the left is our INSTI testing technology. It's a very quick test. It's the 4th generation. It's a very rapid test, like I said, so you get your results in under 60 seconds. This particular test tests for HIV antibodies, and the window period for this test is 1 to 3 months, but the results can show up, the antibodies can show up to, as soon as 20 days. So with this test is very accurate. It's over a 99% accuracy rate. So this one is just testing for your antibodies. And the one on the right is one that we use for our confirmatory test in the outreach setting. So in the instance that we do receive a positive result from the INSTI test, we move on to doing a confirmatory test for you with this testing technology on the right. This one is a 4th generation as well.
This one takes a little longer because of what it's testing for, but the test takes about 15 minutes, which is still fairly quick. This particular test tests for antigens as well as antibodies, and the window period for the results to show on this one are 14 to 17 days. HIV care and treatment. So ERC offers HIV rapid stabilization services here in the clinic. So the client will receive initial labs as well as prescription for the first 30 days of medication on that same day of diagnosis. So if we do test someone positive, on that same day, if they're able to get there, that'll be the same day that they receive their first 30 days of medication. We provide linkage and navigation support to ensure client attends first medical appointment at their medical facility of choice. So they don't always have to come directly down to the Empowerment Resource Center. Like I mentioned before, we do test in a number of different counties. So if someone does need a medical appointment somewhere else, we can refer them there as well, but we still want to make sure that they access that first medical appointment. So here we initiate counseling support to identify barriers and address social determinants of health, which can include housing, employment, and reading literacy. This step is usually started in the outreach setting because sometimes, of course, we do test different transient clients that we may not have ease of access getting to them. We may not be able to reach them via phone or email or something like that. So we try to get as much of that done as possible to get them the best care. We can also provide long-term HIV care here. So if they do decide to come here for care, we can provide that full long-term HIV care as well. Like Brittany and Lauren mentioned, they'll continue to do labs and stuff with them, make sure they're adhering to that medication and everything like that. We offer partner services support. So we initiate contact with sexual partners to offer testing as well as linkage services if needed. So this can be useful in an instance where, of course, we have people that are in relationships or marriages. They may get tested and they may not feel as comfortable contacting their partner to tell them that they even need to get tested. So we can assist in that as well. We can have them come in, provide free HIV testing for them, as well as getting them linked to services if they need it as well. So we assist clients with medication adherence to achieve viral suppression, and Brittany talked a little more about that. Prevention and risk reduction. So like I said before, we provide health literacy programs. These programs are used to promote education and awareness of HIV transmission. We provide these literacy programs on an individual as well as group level sessions. So a lot of times when we go out to different facilities, we usually pair providing these programs as well as free HIV testing for them because of course we want to educate people and provide them with prevention and risk reduction tools as well. We offer safer sex kits. Each kit contains condoms as well as lubrication. We give these to anybody that wants them. You do not have to get tested to receive those. And then we also try to make sure that we provide at least one safe sex kit for each person that gets tested. We provide HIV and STI counseling. This identifies risk behaviors to HIV and STIs, safer sex injection practices, and action plans to address this. So typically we do this counseling piece in the outreach setting when we're going through our demographic. This is a great way for us to assess kind of like an action plan that a person needs or something that they just may need from us. A lot of times this is when people express the most interest or they learn the most from us because the type of questions that we ask, we try to kind of get a feel for other services that they may need that we provide. And then based off of their answers, we usually can come up with the on-the-spot action plan. So for instance, if we go through our questionnaire and someone was to answer that they frequently have sex, they may have one sex partner or more than one sex partner, which is common. And then they also may say, no, they never use condoms or protection. So this will be a time for us to kind of develop an action plan to kind of say, well, why don't you? Based off of those answers, we can provide different things like using different types of condoms. Some people may have allergies and different things like that. So we can usually provide an on-the-spot action plan then. All right, so like I said before, if anybody is interested in partnering or having us come out to provide services to you and your community or anybody that you think is interested, this is a way for you to contact us. Our Instagram and Facebook, here's a QR code on here as well. You can access us there, or you can even email me directly with my email on the right. You can give me a call, and if you need to request an appointment with the clinic, you can go online. Our website is here on the right, as well as our phone number.
All right, thank you so much. And Janae, just another quick question based on something you talked about here before I open it up to all of our panelists. You talked about the Empowerment Resource Center can help with notification. So what might that look like? You talked especially in those awkward situations where you may not want to notify somebody. How exactly would that work?
So basically, it's kind of up to the client's discretion. So like I said, we may have someone that has been married. I'm just going to give an example that has been married for 5 or 6 years. And they may have been newly diagnosed. They may not be as comfortable telling that information to their partner. So with their discretion, we've had instances where people just say, hey, let's go get tested together. And that'll be the time where they bring them in. We'll be able to, of course, with the discretion of the client, we'll be able to tell them their results and tell them, hey, this is why it's important for you to get tested. We want to look at making sure you get care and making sure that you're safe as well. So even in that instance, if it is where that partner is still negative, we can then still go on to providing risk reduction, making sure they're protected, relaying information to them about their partner status. And then we usually can bring them in and they'll have a conversation then, but that is usually like an opening conversation to build the comfort level between them.
Okay. And a couple questions here for either Brittany or Lauren about PrEP and PEP. First one, let's talk about PEP. If you want to get that, is that something that you can go to your doctor and have them prescribe, or do you have to go to an emergency room to get access?
So it really just depends on who's available. If your primary is available, then yes, they can prescribe it for you. You do have to have labs to go along with that. Like I said, checking your HIV status, you want to check your kidney function. But if you only have 3 days to get the medication, so if you are unable to reach your primary, by all means, yes, you can go to an emergency room, a health department. You can come here to Empowerment Resource Center. We'll be more than happy to get it for you. There are many options out there for you. But yes, you can definitely go to the ER to get it as well.
Okay, and then another question from Latonia about PrEP specifically. Is there anything that would make somebody not a good candidate for that, or any side effects that may come from PrEP?
So go ahead, Brittany.
No, go ahead.
Okay. All right. So yes. So people who have, one of the main side effects and one of the reasons we check labs, specifically kidney function, is because PrEP can potentially cause some damage to the kidneys. So we're very careful about checking kidney function every 3 months when we have somebody on PrEP. So having pre-existing kidney problems could be a deterrent to putting somebody on PrEP. Also, Truvada is one of our older versions of PrEP, and after several years of use can cause bone density loss. So again, something we're monitoring people for. We make sure they don't have any bone health issues, histories of fractures, history of osteopenia or osteoporosis before we put on PrEP. So those are big ones. As far as side effects go, we mostly see GI side effects, gastrointestinal side effects. So upset stomach, diarrhea, nausea. Sometimes people have vivid dreams, but in my anecdotal experience, most people have these for maybe 7 to 10 days, and they typically go away on their own.
Okay. And then we got a number of questions just talking about the numbers in the African-American community. And I know you touched on just some of the stigma, right, Brittany, that comes with it. But outside of that, what do you think we can do to combat those rising numbers among women, especially since there are a lot of women here, and men in the Black community fighting the stigmas related to homosexuality even?
We have to talk about it. We have to have conversations about it and make people more comfortable. It's okay to talk about sex. It's okay to just to have these conversations with your family members, your peers, because HIV is here and it's not going anywhere. And then we have to take control of our own health, and we can't put it in the hands of anyone else. So if you're having the type of sex to where it's a little bit higher risk, then it's okay to come to the provider and say, hey, I want to get on PrEP. Like, we have to make it normal pretty much and erase the stigma. We have to erase the stigma.
Right. And so obviously right now there's not a cure for HIV. So it's all about treatment, right? And I also want to talk more, I know we talked a bit at the beginning about some symptoms, but what are some things that you may notice to say, I should go get a test?
As far as for HIV, so acute HIV presents like the flu. There were a lot of people that were going to the emergency rooms during COVID thinking that they had COVID, but they really had HIV. And then also I've seen patients who've come in who've had sore throats and swollen lymph nodes, and they've had just multiple bouts in the ER, been given antibiotic after antibiotic, and they were never tested for HIV. And then come to find out it was actually HIV and not, strep throat, pharyngitis, anything like that. So it can present like the flu. Lauren, if you want to add anything to that.
Yeah, I mean, I agree. Skin rashes, just malaise, night sweats, things like that are very general that we don't necessarily think, oh, this is HIV when this first happens. But yes.
Okay. I'm seeing some questions come in, and please continue to write them in the chat. We have about 5 to 6 more minutes here. This one's from Cherie. She talks about a lot of commercials running on urban radio that can downplay the seriousness of HIV. We just talked about the stigma there. But she said, couldn't that also lead individuals to think that HIV is no longer a big deal? How do we balance eliminating this? Oh, that's a good one. Eliminating the stigma, but also stressing prevention.
That is great. It's education, educating yourselves. There's a lot of things on TV and the radio that can present things not how they are. So as long as you're educating yourself and you're using credible resources, I feel like we can have these conversations, but we can also speak facts and not just, what you hear in the street or what you hear on the radio. We need to have these conversations with facts from educating yourselves.
Right. I don't understand these words. I'm going to try to pronounce them, but do you have support for serodiscordant partnerships?
So with the U equals U, the campaign that came out some years ago, that actually came from I'm sorry.
Can you tell us what that means for people who don't know, like me, serodiscordant partnership?
So if one person has HIV and the other one does not.
Okay.
So there was a study some years back with the U equals U, undetectable equals untransmittable. And the reason that they came to that is because there were about 3,000 couples who one person was living with HIV and one wasn't. And basically they made sure that the person took their medication, their viral load stayed suppressed. And then at the end, they noticed that no one transmitted the HIV, which is why they really, really push U equals U. Because if you don't have a viral load, you take your medication like you're supposed to, then you won't transmit it.
Okay.
We do support serodiscordant partnerships. However, we do recommend that the partner without HIV start PrEP, just to be extra careful and to have that kind of security.
Okay. I was just scrolling through to make sure there weren't any other questions. So I think the last one I will just pitch to anyone here before we wrap up, and I'll talk about some of our programming later today. Can you talk about programming and outreach? Where are you all located? Where can people access you? And then, especially in urban areas, what are the best access points for our community, in particular, the Black community, to get access to PEP, to PrEP, to resources and education?
So we're located in the heart of downtown Atlanta. We're at 230 Peachtree Street at Peachtree Center. So very recognizable area. We have a huge silver statue in front of our building. We're on the 18th floor of a high rise, and we're right on MARTA. So we're easily accessible through public transportation. We have a beautiful building. We have great security. We do COVID screenings and everybody coming in. So there's, we're aware that's a risk, and we are very careful to make sure that people are not answering yes for their COVID screen before they enter the building. But yeah, so we are in a great location downtown, and that's the way Jackie wanted it. She wanted us to be very accessible and on public transportation.
And then as far as the outreach portion, when we go out to different places, like I said, we do cover a bunch of different counties. So we're testing in DeKalb County, Fulton County, Cobb County, Douglas County, Gwinnett County. So like I said, you may see us anywhere. I mean, if there is somewhere that somebody feels like there may be specific need, you can always give us a call. We can assess the area, and we can come and provide free HIV testing for that area as well.
Well, one last question I just saw come in here. Is there any work being done to help influence like general practitioners? This also came up too, to get general practitioners to talk about this more and make testing more routine?
I don't know of any research studies, but I know that as a former I am a general practitioner, but I used to work in internal medicine and family practice. And, we would have conferences and certainly HIV would come up. And yes, we would encourage all of the general practitioners to make sure we were screening for HIV as part of a regular physical exam. But ultimately, it comes down to the discretion of the doctor, nurse practitioner, or physician's assistant to do that. So really, it's just a lot of education at conferences, word of mouth. And then I think it is also on the patient. Not that it's the patient's responsibility, but it certainly gives some patients power to go in and say to their provider, I want an HIV test as part of my yearly annual physical. And there shouldn't be no questions asked if the patient wants that.
Fantastic. As we say goodbye, I think there's a screen maybe we can pull up with contact information for the Empowerment Resource Center. All of our panelists, again, want to say thank you so much to Brittany, to Lauren, and to Janae for all of the wonderful information, answering all our questions. Thank you to our audience for all of your questions. And finally, tonight at 7:30, there's going to be one more panel. It's talking about resilience and impact, prevention, protection, possibilities. We talked a lot today during our panel about ending the stigma of HIV. This panel is really going to expand on that stigma and really celebrating the people, the heroes who are committed to that. You can see on your screen here the virtual conference schedule. You should be registered and have a link. But again, just want to say thank you so much for joining us. Thank you to our panelists. Thank you to our hosts. And with that, we will wish you all a very good afternoon.
Thank you, Madison.